Welcome back. From the Treasury view to the first deep dive into one of our sectors that we're examining as part of investigating the impacts of COVID over the longer term. And of course, the biggest area of government investment in the country is the health sector. And so we have a panel now which examines some of the issues that have been challenging the health sector. And it's been buffeted by a number of trends. Firstly, obviously, COVID itself, and the challenge of preparing and coping with such a large public health emergency. Then, of course, you have the effect of the delay in a whole lot of normal health activity, and by that I mean electives, diagnostics, operations, all those things which would normally would be taking place while the health sector has been in this state of emergency, if you like. The third area that it's been buffeted is, of course, the borders, where the health workforce, a lot of which comes from overseas, has been buffeted, has been unable to come into the country, and that has created some supply challenges there. And then in the fourth, if you like, of the four horses of the challenge to the health sector is the reforms that the government is seeking to introduce and will be introducing later this year. The large-scale operational reforms of the health sector that are taking place at this time during this pandemic. To discuss all these this morning with me, I have three excellent speakers. Firstly, we have Professor Robin Gauld, who's the Dean and Pro-Vice-Chancellor of the Otago Business School and has a lot of experience in health economics. We're about to be joined by Des Gorman, the Emeritus Professor of Medicine at the University of Auckland. Very long and distinguished career in the health sector, including areas like workforce and ACC. And Ranjna Patel, who's the co-founder and director of Tāmaki Health. Now, you may not have heard of Tāmaki Health, but it is the largest independent primary care set of clinics in the country. 300,000 patients, particularly prominent in South Auckland and in the Auckland Isthmus. So that's our panel. We have a total of 45 minutes. We're going to put the pressure on the panelists, get them to talk for 5 to 10 minutes, to lay out their stall if you like, and then we're going to have the conversation after that. So please get your questions ready. The first panelist joining us is Professor Robin Gauld. Robin, thank you very much for joining us and appreciate your opening comments.
Ka tangi te te, ka tangi te kaka, ka tangi hoki aho. Ko taranaki te maunga, ko mokau te awa, ko te mandra te waka. He uri o te whānau Finn, Goldsmith, Adlam, Gauld, Hoki. Ko McGillivray, tōku iwi, no oti poti aho. Ko Robin Gauld, tōku ingoa, ko te manataki o te kurapakahi o te whariwananga o Otago. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Well, thank you very, very much, Stephen, for your introduction. And just want to say it's a real privilege to be here at the NZ Economic Forum and to be an invited panellist. It's a really, really impressive event you've put together. So congratulations to the Waikato Management School for what you've achieved in bringing us together today in very challenging circumstances. So just to overview what I was going to talk about in the next couple of minutes or so, a little bit of history, and then a few words about the Health NZ reforms themselves, which, as Stephen has said, are imminent, and then some really, really important questions that are yet to be broached in terms of those reforms, which will have, in my view, a very real impact on the way in which they are implemented and on whether the government is able to achieve the goals that are set down for those reforms. Underpinning this, of course, is an institutional perspective, and by institutions, those are the underlying arrangements and mechanisms which sit within the healthcare system in this country and in any healthcare system globally. So if we just roll the clock back to 1938, to the Social Security Act, which was passed by the first Labour government, with the goal for healthcare of health being a fundamental right, with all having equal access to healthcare and the same standard of treatment regardless of socioeconomic status or of location around the country. Services being universally available, no access barriers such as financial barriers, a preventive rather than curative focus in the healthcare system, and then services being integrated, not fragmented between primary and hospital-based care. Great goals. When we think today about healthcare, these are the sorts of goals that governments right around the world are focusing on. So quite visionary. But what we then had was a period through which the British Medical Association New Zealand branch, which evolved into the New Zealand Medical Association, really stood up and resisted this legislation, albeit having been passed through Parliament. And what they argued was that there needed to be an ability to maintain private practice, to charge patients a fee for service, and so forth. And so over a period of a couple of years, a compromise was reached between the government and the medical profession, and that laid down the institutional arrangements that we have in place today. And so that is primary care, certainly up until very recently, being dominated by private practice, and secondary care, an ability for the specialists who would be paid on salary along with all other hospital staff, able to take up a private practice as well. And so those are the arrangements that we have in place today of dual practice, as it's called globally, in the secondary care sector, and then a sort of a privately dominated, certainly historically, but less so recently, in primary care. And so this has led to what you might call quite compartmentalised healthcare system when you think about these different institutional arrangements that sit across the sector. And then quite a lot of very intractable questions which governments over the years have sought to solve. And that has led to what I call patriarchy, which has been an inability of governments to dig into these underlying institutional arrangements and then instead try and sort of paste on top of those arrangements different operational structures. And so the most recent version of that is the Health NZ reforms. So if there's one thing you take away today, it's patriarchy. It's pasting of policy solutions on top of underlying institutions. And so on to the Health NZ reforms. In my view, one needs to take a really, really long-term view of these reforms, as one needs to take with any set of reforms, certainly in the healthcare sector, which arguably is one of the most complex components of public policy and of government in any country. And so one needs to take a very, very long-term view, especially when you have fairly rigid institutional arrangements that underlay the reforms that are being set in train. The key challenges with the reforms and the reforms themselves, what we're going to see, of course, is the district health boards being absorbed into Health New Zealand as a preliminary arrangement as they start to move into the actioning of the reforms. The Māori Health Authority will come into play. The primary health organisations will effectively become defunct, but continue to function in some shape or form as they seek to evolve into becoming what's known as locality networks. And so these are what you might call horizontally integrated groups where you would have, say, general practices and then other primary healthcare services integrated with various social services. There's nothing much new in this. Governments over at least the last 20 years plus have been seeking to get this sort of horizontal integration happening between social services and health services. So integration is a good thing, and the government's quite focused on integration, but if you look closely at the Health NZ reforms and the various presentations being given by the Health Reforms Unit, there is a separation between Health NZ funding the public hospitals, the former district health boards, and then funding the locality networks, the primary care. And so in my view, what's really needed is a mechanism for vertical integration. So that's integration between the primary and the hospital sector. And I don't see much prospect for that happening, certainly in the short term. And that's because of the funding pathway leading to a separation of the two. In my view, what's really needed is to take the funding out of the hospitals and to take the funding out of primary care, out of the locality networks as such, and put it somewhere in between. And so that there is a requirement for the two parts of the sector to actually work actively and collaboratively together in order to access the important funding. And this, of course, would give way to the really important clinically led conversations that need to happen between the hospital specialists and other hospital-based staff and the primary care practitioners, general practitioners and other primary care workers. Because once you have those sorts of conversations happening and the funding sits there as well around the table, then you have the capacity to really shift services between the sectors. And again, there's nothing new in this, and the prior government and this government have both been focused on these sorts of questions, but I think the reform's going to work against them, certainly in the short term. Now, if you're able to have those kinds of conversations, you can get services such as, for example, colonoscopy, which is currently requiring a visit to a hospital clinic. The procedure is performed by a gastroenterologist. If you look around the world, you will find that these procedures are performed by nurses with technical skills, freeing up the and out in the community, not in a hospital, freeing up the gastroenterologist's time to do higher-level specialist work. So there's a need to really rethink about the gap between the primary and the secondary and how we're going to resolve that. And then the second point I want to make, just to sort of close up, is that the reforms are really focused on equity. This sits at the heart of what the government has been talking about, seeking to solve the long-standing issues to do with equity around healthcare access and healthcare outcomes in this country. And I think there's a fundamental problem which the reforms are not confronting, and that is the public-private divide in terms of healthcare is delivered in this country. And again, this is not uncommon globally. Every healthcare system in the world has a component of public and of private, but it's how you manage the two sectors which is really critical to trying to resolve the equity issue. And we all know that those who have insurance, which is expensive, or who are lucky enough to have an employer who provides an insurance, and that's not common, or who have deep pockets, can simply pay to get, for example, gallstones done privately next week. Whereas in the public sector, getting gallstones done, you're really way down the bottom of the list, and you're likely to be prescribed morphine and sent back to work until you have an acute episode and are treated on a Sunday morning at 2 a.m. And so, resolving these problems is just not achievable within the current arrangements. And I don't think the government's going to be able to deliver on its goals within the current arrangements. And so to me, and I've thought quite a bit about this, and there is no perfect funding arrangement anywhere in the world. To me, we need to start having a conversation around social insurance for healthcare in this country. Now, if you go to countries with social insurance, and Germany is the prime example, but you'll find it in Japan, Korea, Taiwan, and various other parts of the world as well. What's important about social insurance is that equity is a key focus and solidarity. And so you will find that regardless of who you are, what your income status is, or where you live, you can make a choice, public or private, and the providers all work off the social insurance fund. And so it would mean that the underlying institutional arrangements, public and private sector, which politically are deeply difficult to try and broach, would not need to be dug into any deeper because the social insurance would simply become the funder agnostic of provider. So that's probably some comments to open up with, and I look forward to further discussion. Thank you.
Thanks, Robin. That's great. And thank you for your comprehensive suggestions too, throwing the social insurance on the table so early in the session. I'm very impressed with that. Now, we do have a late apology, unfortunately. Des, we've just heard, has been called away to deal urgently with a patient matter, which of course does happen to our medical professionals, and we have to obviously respect that. So I'm aware a bit of some of Des's feedback on the topic, so perhaps I'll introduce that afterwards briefly. But of course we accept his apology and hope everything goes well there. And we move on immediately to the primary care end of the spectrum. And Ranjna Patel, thank you very much for joining us this morning. And Ranjna, as I said, is co-founder and director of Tāmaki Health, and has a range of perspectives, not just on the current health reforms, but also what's going right and what's going wrong with the COVID response. Ranjna.
Ina mana, ina rio, ina karanga, tanga maha, tēnā koutou katoa. As I'm speaking at an economic forum, I need to put a qualifier in. I'm not qualified in economics in any way. I'm not a doctor, but have been at the coalface of general practice since 1977, starting in Otago. I am now retired from the business and am working in the community with police, creating a different model for family harm in New Zealand, our biggest shame. As you can imagine, 45 years being in the most vulnerable community, my views on recovery and reinvigoration are many. And thank you, Robin. You have covered off the health forum very adequately of my views. Colonoscopy, we decided back, must be 10, 11 years ago, building a whole medical centre in Otago to cope with secondary care, but the funding just couldn't move from secondary to primary. So it's deja vu for me, these health reforms. We've been there, done that, hasn't worked. But as we have limited time today, I will talk on the challenges we've faced in COVID and perhaps a few views on recovery. Workforce has been our biggest issue. We have over 1,100 staff, and over the past 2 years, they have lived up to our values and their profession of here to serve. But they are exhausted and they are tired of being scared. COVID is here to stay. Let's just get on with the work. Our pipeline of overseas doctors has completely shut down. And with the vulnerability of our ageing workforce, our able staff have had to step up to cover. But there are 47 doctors I know of that have passed their NZRX exam part 1 and are unable to get placements in hospitals or in general practice to get their registration. And general practice isn't allowed to take them. When 42% of our doctors are overseas trained and we don't have enough here, we need to create a pathways for the ones already sitting in New Zealand to help with our healthcare system. A bit of background on this. My husband arrived in New Zealand in 1974 from India, and no one would give him a pathway to registrations. Hospitals would say, get your registration, we'll give you a job. And medical council will say, get a job and we'll give you registration. It took 6 months for someone to sit this American ECFMG exam and we'll give you your registration. At least he had a pathway, but we don't have a pathway in 2022. Since the mid-80s, immigration changed their laws. And we have a lot of overseas doctors and nurses coming into New Zealand that are not registered in New Zealand. Majority because, especially nurses from the islands, cannot pass the English exam, which my nurse leader on several occasions said she would have trouble passing. These people we've employed, they are the unemployable because they are not doctors, they are not nurses, they are not project managers, but we employed them to be our diabetes educators, recalling and talking to patients about preventative health. They have come from an environment when they have done outreach clinics in remote areas with little diagnostic support. They have delivered babies, they have done diabetes education, they've done immunization, they've done minor surgery. So even though they are only using a fraction of their knowledge, they got to know the New Zealand health system. By building their confidence and then shadowing doctors, many have got their registrations to being nurses and doctors. Another example is a Tongan health practitioner that we employed. She could not get recognised as a doctor or a nurse because she didn't fit into any category. She could just not move forward. She has worked with us for 20 years as clinical family navigator, visiting homes, educating patients on self-management, has put 3 children through private schools through scholarships and seeing them graduate at university. We need to see people's strengths, not what they are not. That's how you provide equity. My second point is the mode of delivery. We need to be patient-centric, not Wellington-centric and not PC-centric if we want to make a difference. We started in Otago and we realised 9 to 5 appointment-based service wasn't going to work and wasn't going to pay our mortgage. It was the population that we were serving. We needed to increase access, time-wise and financially. In those days, phones and cars were luxury in Otago, so we made it walk-in and opened longer hours. Totally against our profession. Must be a dodgy Indian couple. And then we introduced computers in 1984, so patients could go anywhere and their notes would be there. Patients own their notes, not the doctors. Patient-centric. Majority of our clinics across Auckland are on one database. We need to let primary care come up with what works for their patients. It doesn't fit into one box. If telehealth works, and it did during COVID, let's see if we can extrapolate that to do self-management, preventative health, and mental health. We have to look at what mode works for today and for your population, and not be suspicious of a different way of working. Regarding increasing access to healthcare for Māori and Pacific, while we applaud the good work that Pacific for Pacific and Māori for Māori general practice do for their whānau, it needs to be acknowledged that the majority of the Pacifica and Māori are actually enrolled in what is deemed to be mainstream general practice. For example, our practices in Auckland have 80,000 Pacific patients enrolled. 53,000 of those are in counties Manukau practices, making us the largest provider of Pacific and South Auckland. However, deemed being mainstream and not a Pacific providers means the practices serving them don't have any additional resources offered to Pacific providers. Yet our patients don't attend anywhere else, as the practice endeavours to lower all barriers, such as cost, extended hours, and placement of the practice within a high needs communities. We have 4 generations coming through our doors. This highlights that inequality in the distribution of the health dollar. The dollar has to follow the patients, not who you are and what you are in primary health care. COVID has highlighted we are the poor cousins in healthcare general practice. The trust and confidence in GPs from patients has been broken over the 2 years. We are just the ambulance at the bottom of the cliff. History showed GPs could manage outbreaks by getting their patients vaccinated and seen. The first point of contact was taken away from the patients. We look after 80% of healthcare needs and get less than 20% of the healthcare budget. If we do not address this issue, we will be filling the hospitals very quickly. Our chronic disease patients, diabetes, obesity, cancers, are all going unchecked. We have to remove the scare tactics in the community and start to empower people to look after their health conditions. Prevention is better than cure. We have seen a big difference in the new way of managing chronic disease with health coaches, peer supports, self-management, and getting off the couch working with people over 200 kgs. Doctors cannot do everything, but they know what works for their patients and need to be able to let the other professionals and community workers do a lot more of the educating. Mental health will be a big issue. We've seen that in the household, family harm has increased so much. Patients presenting with unknown symptoms have underlying issues with mental health, and we're just not dealing with it. Our in-house psychiatrist, David, says what's been seen in the homes during lockdown is going to take 3 generations to be stamped out of people's head. We do what we see, not what we're told. It would be amiss of me not to highlight the issue general practice has faced over the past 2 years. And yesterday, it was revealed by the MP. It just announced on TV that GPs can do the RAT test from tomorrow. It took all of us by surprise. My CE had to act quickly as people started to demand the RAT test. Stefan said, I messaged Ashley, letting him know that we received only enough for testing staff for 1 exposure event each, and we would have to make an announcement due to the high volume of calls demands from patients. Rapid tests are not publicly available. We had to put this on our website. We have had a very high number of requests for these tests from our patients. However, although they are on order from the Ministry of Health Supply, none of our clinics have been provided their necessary allocations for general public supply or use. We regret we have no visibility of when sufficient supply of RATs will be made available to us. Now, this is not serving our patients. This is not patient-centric. We had this happen with testing. We had this happen with vaccines. And once again, the poor cousins are the ambulance at the bottom of the cliff. Thank you for listening to me.
Thank you very much, Ranjna. And sadly, the story that you've just relayed about RAT tests, unfortunately, does appear to have been symptomatic of some of the things through the pandemic between the ministry and the providers, I suppose, and the people that are with are looking after the patients. I want to cover 3 things in the time remaining, if I can, and we'll start perhaps with that mode of delivery or point of delivery, and then I wanted to go into the reforms and finally a little bit on workforce and perhaps a comment from each of you on those 3 things. If we start with mode of delivery, Robin, I think we're probably hearing symptoms of this issue with funding and that inability to move easily, funding between different modes of delivery, experienced there firsthand with Ranjna and the team at Tāmaki Health. And you picked that up with this whole issue of hospital funding or private funding. And I think it's fair to say the DHB model has definitely meant that it's much more hospital-centric than probably because that's where all the risk is, right? Running a hospital is expensive. But that doesn't solve it from a patient perspective. So I suppose my question to you is, how can we make it work better? Do you agree with Ranjna that the funding actually has to follow the patient? Where the patient wants to be is where the funding should be.
No, I do. And, this is actually a critical component of research and policy and health policy globally now, is the patient perspective. And you can bring real power to conversations around health systems through bringing in the patient voice. I mean, we've had quite a long history of trying to work in this way in New Zealand, but I don't think that we've been able to articulate it as strongly as it could have been, or brought the patient voice into the health system and policy discussions in ways in which we should have done. And again, if I come back to the social insurance, and I don't want to sound like too much of a loud drum, but with social insurance, I mean, a patient decides whether they want to go to the private hospital or the public one or a general practitioner. You can still have gatekeeping with a GP, but it actually gives the patient quite a lot of choice within that context. And you think about ACC, which is, for want of a better term, a form of social insurance, albeit just covering accidents and injuries. So, that funding model would give a bit more power to the patient voice, I think. So no, I completely agree. It's absolutely important that we haven't done a good enough job of it.
And there's almost 2 parts to that, isn't there? There's the funding itself, and then there's how you fund it. So the insurance part is how you fund it. Then the equity part is the part that Ranjna's been talking about. Ranjna, do you see anything in these current reforms that will make it easier for Tāmaki Health to do its job for its 300,000 patients compared to now at this point?
No, we've been through localities, 18 years ago, it didn't work. Assuming all Indians want to go to Indian doctors, all Pacific want to go to Pacific doctors is very limited in its thought. We don't have enough doctors and nurses to cover every ethnicity in New Zealand. We do need to look at, I like your social insurance. It is so important that everybody is able to have service, as you say, with any kind of hip operation, or if you go to private, you can go and do it next week. If you go to public, you're not that bad, you can wait 6 weeks. We saw over COVID that our platform, Better, worked very well with patients, but it worked with patients in rural areas where they couldn't get to GPs. And because we made children free, a lot of parents were ringing to use that service for children so that they could get health care. Our funding model doesn't allow any creativity. And so over COVID, we set up this Better platform, but we couldn't charge the patients. And because we've never, ever made patients not to be seen even if they have large accounts, it's always been my husband and my philosophy that everybody deserves health care. If you have patient loyalty, and as I said, 4th generations of people coming through us, to us, is patient loyalty. It's important we do the best for them. When we're seen to be ineffectual, like this RATS testing, no one believes that. No, the Prime Minister said you can have a vaccine, but we don't have vaccines. You can have a RAT test, no, but we don't have RAT tests. Our credibility as primary care has really deteriorated with our patients. Our trust and confidence, saying, well, you know, someone's telling us you can, and you can't really. So if we just allowed more people to be able to deliver different types of health service to what is needed, self-management, peer support is invaluable to a lot of our patients. Deterring from health a little bit. You know, when we talk about mode of delivery, I've started a family harm project with the help of partnering with police, where you look at the perpetrators and you reform the perpetrators, because they are 95% of the offenders. Now, if you don't change the core problem or address the core problem, our family harm statistics are going to stay the same. And I was criticised for working with the scum of the earth, the perpetrators, but majority of the women take the men back, and we're giving them no tools to deal with the next episode. So massive research has been done on our program, with 60% over a 5-year period did not reoffend again, internationally unheard of in family harm projects, but it's still seen as something suspicious. I started it for Indian men, and now it's majority Pacific and Māori. And so if you do it with patient-centric, it works for everyone. And I think the mode of delivery has to focus on being patient-centric, what will benefit the New Zealand health system if we work with the core need of the patients.
So what I'm hearing from Ranjna and Robin, and you can both correct me if I'm wrong, is you're not convinced, and Des was the same, by the way, in the notes that he and I discussed ahead of time, that the health reforms are in many ways just rearranging the bureaucracy, to put it perhaps less than charitably. I mean, the people work hard, but nevertheless, there's a rearranging of the bureaucracy. Until we get to a much more patient-centred, money follows the patient and their needs, then we're not really going to change things too much. Okay. I'll take that as we're at, because I want to move on to one further thing, and that is the workforce challenges. And we've had a couple of questions here. We've got our own nurses and doctors still leaving the country. People want to know why that is, when we're bringing in 40-odd% of our doctors and nurses from offshore. And they also want to know with 2 years of the borders closed, how big is the hole? How desperately are we in regards to the health workforce? And are we going to be able to solve it using our normal training methods? So perhaps if I go with you, Robin, first, and then Ranjna. We've only got a few minutes, but a quick comment from each.
Yeah, look, no, thanks. This is a really important question. I'm of course not at the front line, but we historically have been the highest importer in terms of total doctor percentage of foreign-born and trained doctors in the OECD. 46% of our doctors, one in four doctors from the UK, and nurses is not far behind, and it's a revolving door. About half of those doctors will only stay here 2 years, and this is pre-COVID, and then go back overseas again. They might come here and then go to Australia or go back to the UK or wherever they've come from. So it's a historic, very pressing and very real problem. Part of it's to do with the training, I think. We have been increasing the number of certainly medical trainees and nurse trainees and other professions. But part of it also, I think, relates to scope of practice, the point I was making about gastroenterologists undertaking colonoscopies. And if we were able to have, and I know that Des has been very involved in these conversations with Health Workforce NZ, they're really challenging because of the strong protection of interests within, for example, the medical colleges. So as I said, elsewhere in the world, nurses are trained to work under the supervision of a gastroenterologist to do the procedures. So they can spend all day doing the procedures and free up the gastroenterologist to do other work. But there's a private component to this as well. And I'm not going to make accusations. You can have your own thoughts about this, people here today. But private gastroenterologists, do a lot of work privately. So there are really important conversations to be had around all of this again. And this is why I come back to the social insurance concept, because it's agnostic of where you provide the service. The funder has a fee schedule and a method for sort of funding the different services. So you don't have to dig into these really difficult questions. But I think the scope of practice one's a really important one.
Thanks. Ranjna, two things then. One is how big a problem are we dealing with right now? What's, on the front line, what's the shortage like? Are we likely to recover from it in the next year or two? And then secondly, the scope of practice question. Should we, for example, be letting practice nurses do more? Should we be letting radiographers do more, for example, rather than relying always on those relatively small number of specialists at the top of the system?
From a general practice point of view, first of all, the workforce, we are at critical stages. We have the added problem of people going back home to UK and Australia. Our doctors, especially our 24/7 centres, we run 2 in Auckland. Our local doctors don't want to work the evening shifts or night shifts. And so it's usually the overseas doctors that are manning them. UK and Australia, you're right, Robin, most of them do go back. The money's a lot better over there. The 47 doctors I'm talking about are all ethnic doctors that would be wanting to stay in New Zealand, and yet we're not letting them. The nurses, we have the added problems of the nurses being attracted to the DHB on much higher pay scale than general practice can offer. And so we've lost quite a few nurses to hospitals who have come back again. You earn more being a vaccinator for the DHB than you do in general practice. So yes, economics has played such a big part to the doctors and nurses moving, and job security and longevity. Scope of practice, yes, it's such a limiting thing in patch protection for the Medical Council and the Nursing Council, that they do not recognise anybody's capability of doing it. And we, as general practice, see the benefit in peer support and self-management from people that have lived the disease. And mental health, people that have gone through it are much more able to communicate with people that are suffering from it. And so the scope of practice, it limits so much of what the professionals can do, what lay people can build up to do. And so we need pathways of doing it. We don't have enough doctors in New Zealand that are going to qualify. And everyone's ambitious. The Kiwi way is to have 2-3 years overseas. And that's going to happen, even though we've got more doctors in the system at the moment. Most of them will be going overseas for their OE. And so, you know, we're in the same dire situation that either we increase it dramatically and allow overseas doctors in from accredited universities that can get registration, a pathway into general practice, because the hospitals can't cope with them. These 47 doctors need to get hospital space, and no one's giving them jobs in hospitals. So the scope of practice and who's doing what is so important. And let general practice decide who does what. You know, the college can say, scope of practices. We just, you know, I can't put this on the government. This is the governing bodies of the different institutions that are limiting what is able to be done in New Zealand.
Feels like scope of practice needs looking at. It feels like the method of training needs looking at. I'll throw a plug in for the host university here. They're pretty keen on a third medical school. I know in your neck of the woods, Robin, they probably wouldn't be quite so keen. But you know, it's something that it feels like its time has come. I mean, we need to get on, not necessarily the same as the other two medical schools, but perhaps one focused particularly on general practice or something like that, which just provides those opportunities, greater opportunities for people domestically to increase the supply, but also we're going to have to be working pretty hard to bring people in, because I imagine we're in a very competitive world at the moment for doctors and nurses of all specialties and generalities. Look, can I thank you both very much for your time this morning and also stepping up in Des's absence. I think you've represented very similar views to what Des would have offered in terms of the views on the reforms. I think that hopefully there's something there for Minister Little to think about. It'd be a terrible travesty if we do all this reform and we end up having the same conversations in 3 years' time, which sadly looks possible, at least at this point. So thank you both.